So, hello everyone. Today we shall take a quick look at the Kawasaki disease, which is one of the common manifestations we see in children and commonly missed and misdiagnosed as other things like drug reactions. And usually this condition can be fatal if misdiagnosed and then you don't treat the patient in the due time. So as we can see in this picture, we see a child with a lesion on the lips. We see a rash in the palms, and we also see a rash in the genital area. Then we also see swelling of the feet and also swelling and erythema of the palms. So in this animation, I put for you a big heart. So that you remember that in Kawasaki disease, the common thing that we usually fear is involvement of the heart or a complication that can affect the heart, more especially the coronary heart vessels. So in Kawasaki disease, we look at it as a multisystemic disease condition, but of unknown etiology up to now, but it is commonly seen in children, especially those below the age of 9. It is also called the mucocutaneous lymph node syndrome. And usually I like this synonym because it gives you the picture of the involvement of the disease. So mucocutaneous, meaning it involves the mucous membranes, the skin. You have lymph node enlargement, and that makes it a lymph node syndrome. And in this case, you also have a vascular involvement or the blood vessel involvement. So Kawasaki disease commonly affects children, especially those under the age of 2 years. But sometimes it can also occur in those that are above, even those that are above even 10 years, it can occur there. And sometimes that makes it even very hard to diagnose if it occurs in more older children because it is less expected there. So systemic symptoms include a fever, a generalized rash, and lymphadenitis is commonly affecting the cervical lymph nodes. And the common complication we see is myocarditis and arthritis. Still, the exact cause is not yet known, but bacterial superantigens have been postulated to be the potential triggers, but yet to be confirmed. So it was first described by a doctor called Kawasaki in the 1967 in Japan. And it is seen worldwide with a little geographical variation. And in the United States alone, you see that they report up to 300 cases per year. And in our setting here, it is not well documented, but I think it is also occurring, but going unnoticed. So as we have not had any epidemics reported for Kawasaki, and when you look at the age and sex distribution, we say that it primarily affects children, rarely seen in adults, and oftentimes seen in males and then also siblings. We have been postulating a possibility of transmission, but this is not yet proven. So there's no direct transmission from one person to another as of the current data. The exact cause, we say that it is not yet known, but it still remains to be identified. However, we have different hypotheses that try to explain how maybe this condition can be coming about. The first one, we call it the environmental hypothesis, which thinks that maybe there may be a waterborne or airborne pathogen that triggers this condition. And the second hypothesis is the genetic predisposition, whereby individuals with particular genetic phenotype and genotypes appear to be at more risk of developing this disease. So this includes the human leukocyte antigen B51, the human leukocyte antigen BW22J2 serotypes, and we also have the CCR2 and CCR5 halotypes. All these have been associated with an increased risk of developing Kawasaki disease, which can be as high as 20 times as compared to other individuals with other genotypes and phenotypes. The lucky thing is that in this case, we've not been able to confirm any evidence of it being contagious, being person-to-person spread. And we've been suspecting multiple bacteria, including the staph and strep, and other viral organisms being suspected, but no confirmatory tests have been done to show that actually they're the ones that trigger this disease. However, notably, in one particular study, up to 40% of the children who were diagnosed with Kawasaki had a positive test for a viral respiratory pathogen. But this could be incidental, could as well be maybe present, but not actually explaining the causality of the disease. So, still in the pathophysiology, we look at the hypotheses that we have. The first one, in the early years, they used to think that maybe it was caused by the electrical species and it was due to exposure to dust, the dust mites. But after a long time, they discovered actually this is not true, and the recent evidence suggests a super antigen that causes activation of the T lymphocytes to be the underlying pathogenesis. But even this is not yet proven. So bacteria like staph and strep pyogens have been implicated, and the major complication usually fear in this case is the coronary heart aneurysms, which is usually secondary to the vasculitis that is a component of this disease. So in the pathophysiology, we have either an infectious trigger, whatever trigger that it is, which is most likely to be maybe respiratory in nature, that activates the immune response. So in this case, when you activate the immune response, you'll end up having a production of tumor necrosis factor alpha, interleukin 1, interleukin 4, and interleukin 6. So because of the activation and these interleukins, they now trigger an immune response that causes the eventual damage to the vasculature, and then you end up with a systemic manifestation. We all as well know that these inflammatory mediators and cytokines, they also cause a rise in temperature, so that's why the child will have a fever. Then other chemical mediators that have been implicated includes the oligoclonal IgA plasma cells that are thought to cause the damage within the coronary arteries, but we also have a thought that is activation of the matrix metalloproteases, especially the MP3 and MMP9, that eventually cause the degradation of the matrix connective tissue, causing the damage to the vascular wall that ends up presenting as aneurysms in these particular blood vessels. So when you have this vascular injury, most of the times it can involve the myo tissue, that is the heart tissue, the arteries, especially the coronary arteries, and then you end up with fibrinoid necrosis that weakens the blood vessels, and then you have neutrophils that invade and lead to aneurysm formation within this vasculature. And sometimes you have a unique activation of the monocytes and macrophages within the vascular lesion. So the vascular injury, as per se in this case, is coming because one, you activate the immune system, then you end up producing inflammatory cytokines within the bases of the blood vessel. So when you have that, then you have recruitment of neutrophils, sometimes monocytes and macrophages, then production of this matrix metalloproteases that will come and damage the vasculature within the body. So they will damage the vessels, resulting into formation of aneurysms. So that's how the injury will come about. And in this case, we have cardiac complication. The first one being the risk of myocardial infarction. You can have rupture, you can have arrhythmias, and then sometimes you can end up with thrombocytosis. Then coronary aneurysms are pretty much very common in Kawasaki. And then at the end of it all, you can also have wall thickening stenosis as a complication as the patient heals, and then thrombus formation, which occurs over time. So we also get small aneurysms, which may resolve in 90% of the cases during convalescence period, and these ones in most cases they go unnoticed. So when we look at the clinical picture, how does a patient with Kawasaki present like? So in most of the time, or more oftentimes, the patient will have this acute onset of a high-grade fever, which will be very, very persistent, lasting about 5 to 7 days. So when you see a fever that is not going away in a child, then you have to think about Kawasaki, and more so if this child as well has mucosal involvement and conjunctival injection. Sometimes they get this dry lips, fissuring, and then strawberry tongue, and they usually have a classical reddening around the lips, the oral mucosa, and then also conjunctival injection. Then the other feature that we usually look for is the rash that most of the times is generalized but localizes on the hand and feet, followed by scaling, and most of them can also get edema also of the hands and feet. So other signs that we usually look out for, you look for cervical lymphadenitis or lymphadenopathy, and in this case you see palpable regional cervical lymph nodes, and then you start to suspect Kawasaki. So myocarditis is also seen in about 25% of the cases, and this will have arrhythmias and then tachycardia. You can also get pericarditis with valvular incompetence, and as well as coronary artery aneurysms. So in this picture, it tries to highlight the most important features that we usually see in Kawasaki. So if you could memorize this will be very, very beneficial, such that you can always remember if you have a child having a fever lasting more than 5 days, then they have palpable cervical lymph nodes. We know a lymph node is significant if its diameter is about 1.5 centimeters. Then they have this conjunctival injection, which is more oftentimes non-exudative. So that would differentiate it from the bacterial conjunctivitis. Then they have this reddening and mucosal involvement with mucositis. So, and then they'll have heart issues. When you listen to their heart, either they have an increased heart rate, that is the tachycardia, and maybe they have abnormal murmurs because of maybe valvular incompetences. Then this child is having maybe swelling of the palms and the sole, hands and the sole, and then this generalized rash that is usually maculopapular, and then he usually heals with desquamation. So when you have all these features, you have to think about, because oftentimes it goes unnoticed because it is self-limiting, so it goes unnoticed. But if the child is unlucky, then it complicates, then it will give them the cardiac complications. So we have a diagnostic criteria that we usually use, and the first key feature is a persistent fever for over 5 days, and then presence of these principal features, including bilateral conjunctival congestion or injection. Then you have changes on the lips and the oral mucosa, which we call mucositis. Then you have this polymorphous echinanthema, so it can have arterial lesions like arterial lesions. It can have morbidform like eruption, and it can also have papuric lesions. So we can also have changes in the peripheral extremities, especially the hands and feet, with edema, swelling, redness, and then also we can have an acute non-prurient cervical lymphadenopathy. So when you see these features, so you can make a diagnosis of Kawasaki disease. So we also have this acronym. You know, I love acronyms because they help you remember the condition, even when all things have gone. At least you have something to remember the condition for. So the acronym I usually use in Kawasaki, I call it warm cream, or you can call it warm cream, or you can just say febrile. So whenever they say Kawasaki, just say warm cream or just say febrile. Say that you remember. For example, if you're using warm cream, the warm just simply means a fever for more than 5 days. Then C will stand for your conjunctivitis without exudate. The R will be for the rash. E will be for edema or erythema of the hands and feet, followed by desquamation and nail changes. Then A will be for the adenopathy, where you'll have now your cervical lymph node enlargement. And then you have M standing for mucosal erythema. So that will be the cream. So if you're using febrile, then F will be for fever, then E for echinanthum, then B for bulbar conjunctivitis, R for rash, and then I for internal organ involvement, which is usually the coronary arteries, abdominal organs, the lungs, pneumonitis, hepatitis, and bronchitis. And then E will be for extremity changes, which include the initial edema, erythema, desquamation, and then the nail changes. So this acronym at least tries to make you remember the key important features that we usually see in Kawasaki. So Kawasaki is one of the conditions that presents with a strawberry tongue, just like in scarlet fever. So every time you see scarlet fever, and you make a diagnosis of scarlet fever, please include a definition of Kawasaki disease, because that will save you a lot. So in case someone you think scarlet fever, they have that sandpaper rash, but then they have these persistent fevers that are not going away. Now eventually the child develops maybe a mucosal rash and then conjunctival injection and the rest. Then you hear the heart has issues. So that makes you think about Kawasaki. So please remember that. So what do we see when we do histopathology? So when you take off a biopsy from these lesions of Kawasaki, because it is a form of a vasculitis, so you expect changes around the vasculature. So though we rarely perform these biopsies, and most of the times not necessary, but if it is early, you will see neutrophilic mediated destruction of the vessel media, and if it is coronary arteries, you can see granulomatous inflammation, which begins about 6 to 8 days into the illness. So if you take off the biopsy within day 2, day 3, and you're suspecting, you may see little or even more changes. Then it will usually affect all the layers of the vessels, starting from the intima, the media, and the rest of the and endothelium. All the layers are usually affected. And during this progression, the inflammation of these blood vessels is usually replaced from neutrophil based to lymphocytes and monocytes, and then you have fibroblasts, which will end up giving you the remodeling, the fibrosis, and then you end up with kinking of blood vessels, or sometimes strictures or vascular stenosis and the rest, because of the remodeling that occurs mediated by the fibroblasts. So microscopically, you can see cytoplasmic inclusion bodies with the RNA found in about 80%, 85% of the acute cases, and then late stage usually facilitates you to use, if you're able to use electron microscope and the rest, you can also pick these other changes. And then what differentials do we have to exclude? So in this case, since it is a febrile illness, you need to exclude all other infections that can cause febrile features like other viral exanthems, viral myocarditis, rheumatic fever, toxic shock syndrome from streptococcal infection. And then we can have also complications and comorbidities that come with Kawasaki. These ones usually include the coronary artery aneurysms, the arthralgias, arthritis, erythema. For me, you can end up with proteinuria, hepatitis, and then aseptic meningitis. So what treatment plan do we usually give in Kawasaki? So the goal of treatment in Kawasaki is usually to prevent the complication, which is cardiac involvement. So in this case, you want to initiate your treatment in the due time, as early as possible. So if the patient is still early and then you're suspecting, then you can start the IV immunoglobulin at 2 grams per kilogram body weight over about 10 to 12 hours. This is usually advised to be started within the first 7 to 10 days after the onset of the fever. Then this one helps us to reduce the risk of coronary artery aneurysms from 25% to about 3 to 5%. So that's a significant. This is a very significant improvement. So if you have a patient who's suspecting Kawasaki, right away give IV immunoglobulins, and then you'll prevent them from developing the cardiac involvement. Then in cases where you don't have the IV immunoglobulin, an alternative will be aspirin, which is given at a dose of about 80 to 100 milligrams per kilogram body weight. And this is usually given until the patient is febrile. That is usually more than 2 days. Then we can also give a low dose, which is 3 to 5 milligrams per kilogram body weight, to continue for the next 6 to 8 weeks. So after the acute phase management, then you taper down the aspirin to give a low dose, which the patient is supposed to receive for the next 8 weeks. So there's also a risk of Rett syndrome, especially if the patient has actually influenza or maybe varicella. So you have to be cautious as you're giving your aspirin. Alternatives, we can also give clopidogrel, and they also can also give the dipyridamole. Then sometimes we get IV IG resistance where it doesn't work. So sometimes 20 to 25% of the patient may also need a second dose of IV immunoglobulin if the fever persists for more than maybe another 38 hours. That is 1 day and a half. So if you give the first shot of IG and then the fever is still persisting, then you can go ahead and add another second dose. So the additional therapies that usually use in Kawasaki, we can use also corticosteroids, and sometimes they are beneficial in patients who are IVIG resistant. And in this case, we can give prednisolone at 2 milligrams per kilogram body weight for about 3 days to 2 weeks. And this also reduces the risk of cardiac complication, the duration of fever, and the duration of hospitalization. We can also add some statins in a little bit older patients. These ones also have immune modulating properties. We can also give ARBs that can prevent also stenosis. And now you're now giving statins, and then also these ones are just helping you to cause immune modulation and then also prevent the formation of cholesterol plaques in the vessels, which cause or worsen the vascular stenosis. So in the long-term management, so these patients, once you have made a diagnosis of Kawasaki, they remain your permanent patients because you have to continuously do routine cardiac tests and screening to make sure that they don't have the long-term complications of the disease. And sometimes you may end up needing to give them protracted anticoagulation therapy, where we give either low molecular weight heparin, or we can also give clopidogrel for even long time. But in this case, if you're giving warfarin, you need to continuously be checking the INR to make sure that they are balanced, but not throwing them into hypercoagulability states. Then platelet activity usually remains elevated for about 3 to 12 months, even post onset. So you may find that your platelets, even after treatment, the number remains low for a very long time. So this allows you to keep monitoring these patients so that you see how they are progressing. So most of the times the disease resolves in about 1 to 2 weeks after onset, but sometimes some patients, they can persist for more duration, but the coronary artery aneurysms can sometimes regress within 2 years, but others, they can end up being major, and then they need maybe an operation or something else to deal with the aneurysm. So the potential for life-threatening complication is a little bit high, especially if the patient is misdiagnosed and not started on treatment on time. And usually our biggest fear is myocarditis-related coronary disease, or sometimes AMI, which is myocardial infarction. So when it comes to the cardiac disease, usually the prognosis depends on the severity of the coronary heart involvement, and sometimes it also depends on the age of the patient. So if the child is below the age of 6 months, or if the child is above the age of 9 years, usually these ones carry a poor prognosis. Reason being, they are usually diagnosed late because people don't expect Kawasaki to occur in those particular age groups. Then if there's a recurrence is a little bit more rare, but sometimes it can recur. And some few cases have reported recurrence complicated with cardiac complications. The mortality, usually all Kawasaki disease-related deaths are usually due to cardiac complications. So that means that we need to manage in time to prevent heart involvement. Typically, they can occur between maybe 15 to 45 days after the onset of the fever. So what should we remember, or what are the important things that we have to remember in Kawasaki? So if you suspect that a child has Kawasaki, it is imperative for you to do an echocardiogram to make sure there's no heart involvement. And then we know that late diagnosis leads to severe complications. So every time you see a child having a fever and a rash, you should know the algorithm that you should go through to make sure that it is not Kawasaki disease. And then when you're evaluating for incomplete Kawasaki disease, the one which has no other, like which doesn't accomplish the criteria, you can be also guided by these other investigations, including ESR and CRP, which are reactive proteins, liver proteins. You can do a CBC serum albumin, and then you can as well do liver function test, where you'll get a picture of the alanine aminotransferase, and we can also do a urinalysis to see if there's any derangement. Then the common pitfalls when you're making a diagnosis, usually in some patients, the initial presentation can be very vague, whereby someone just has maybe fever and then unilateral lymphadenopathy without maybe the rash or involvement and the conjunctival injection. So that can even delay the diagnosis. And sometimes the rash and mucosal changes may be misinterpreted or just given to other dermatoses like antibiotic reactions, maybe drug reactions, maybe other viral exanthems like measles. So before the child is diagnosed with Kawasaki, they have seen maybe 5 different doctors. Then pyorrhea may also be confused with urinary tract infection. That's one usually seen in Kawasaki. And then sometimes if someone gets meningitis, this can also be confused with other viral meningitis or even bacterial meningitis. When you take off a sample for CSF analysis, you may find that the feature are similar to those ones we see in viral meningitis. Then you can also get viral symptoms with a positive PCR that can be misleading. So you can maybe get a child who is convulsing, but when you do a PCR, then you find that maybe it is positive for herpes simplex virus. So you may think maybe it is a meningitis due to herpes simplex virus. Yet it is actually Kawasaki, and the treatment is actually very, very different. So we usually recommend you do an echocardiogram, the ECG. Yeah, initially when you make a diagnosis, you have to do one, then you repeat another after 2 to 8 weeks post-diagnosis. And then there's a recommendation that you have to do an additional echocardiogram, like at day 10 to day 14. Then you can do and then 4 to 6 weeks. So depending on which protocol you're following, then you can use the different guidance. But mostly in our setting, we usually do at the diagnosis, then 2 weeks after, then at 8 weeks after the diagnosis is made. Now, remember the treatment goals that we have in Kawasaki is to prevent cardiac involvement, and this can be done very well if you can give IV, immunoglobulins, or even aspirin for patients with Kawasaki disease. Long-term follow-up requires you to monitor these patients for any cardiac issues, even when they reach their adulthood phases. Thank you very much. God bless you. I'm Dr. Abraham from here in dermatology specialist. See you in the next video.